Welcome to all the rest of you familiar faces. We're very appreciative of your support. Today we're going to be talking about faith and end-of-life decisions, and our speakers are all ready or coffeeed up and very hyped up to get this conversation going. But we're going to start with lunch. So I will call Reverend Dr. Steve Street, Odile's husband, to pray for the lunch, and we'll get going. In practice from the U of Minnesota, and he practices as a staff nurse on a per diem basis in the Oncology unit and Palliative care unit at Sanford Hospital in Fargo. Jack?
Thank you, Faith. Happy Valentine's Day, everybody. When Paul asked me last fall to co-present on this topic, he mentioned the date to me, and at the time I really didn't think about Valentine's Day, but now that I reflect back or think about it, I actually came across one of my colleagues here at Concordia this week, and as he said, there's nothing that screams Valentine's Day like a conversation about end-of-life care. So be it. Many people with serious illnesses engage in a process of reflection on the meaning of life and on the major spiritual and existential questions of life. One's faith plays a significant role in assisting us as we work through the matters that must be addressed as we face end of life. For many of us, our faith is a defining characteristic of who we are. And what Lauryl and I would like to share with you today is a glimpse of our insights relative to the role of faith playing in addressing end-of-life care decisions. Naturally, these experiences and insights are derived from a combination of our professional as well as personal experiences. Both Lauryl and I have worked in hospice in different aspects and have a variety of different experiences, I guess, from this perspective. But Dame Cicely Saunders, who was the founder of St. Christopher's Hospice in 1967, and she's credited with really pioneering the field of palliative care and the modern hospice movement, perhaps said it best when she said, speaking to the importance of living how we desire and spending our final moments, you matter because you are you, and you matter until the last moment of your life. So I just want to give you a little outline in terms of where we're going to go here today with our conversation. We want to start the conversation with making sure that we're all thinking about some of the terminology that we're using, that we're looking at it from the same perspective. So I'm just going to give you a couple definitions of a couple terms that we're going to talk about. I'm going to share with you a brief overview of the literature in terms of faith and end-of-life care. And then I want to share with you just a little bit about a personal experience that I've had recently relative to faith and end-of-life decision-making. And then Lauryl will come and share some of her experiences and perspectives from a chaplain's perspective, specifically a hospice chaplain's perspective. So that's what we would like to do for you here today. So to start, we'll be talking a little bit about religion and spirituality. And the terms of religion and spirituality oftentimes are used interchangeably. And in fact, the literature identifies that most of the research prior to 2000 used the words religion and spirituality interchangeably. However, when we talk about spiritual needs, this really tends to be based on the premise that spirituality is a much broader concept than religion. And for our presentation today, we'll use the premise that religion is an organized system of beliefs, practices, and symbols designed to facilitate closeness to the transcendent and to foster an understanding of one's relationship and responsibility to others in living together in a community. Spirituality, on the other hand, we're going to be working from the premise that it's those beliefs, values, and practices that relate to the human search for meaning in life. For some people, spirituality is expressed through adherence to an organized religion, so that's very synonymous with religion. While for others, it may relate to their personal identities, relationships with others, secular ethical values, or humanist philosophies. For some people, spirituality is not about religion at all, and actually quite the opposite. Advanced directives are written instructions that document a person's wishes if decisional capacity becomes diminished. Advanced directives may be individual documents, a living will and a durable power of attorney, or it can be a combined document that addresses both the living will and the durable power of attorney together. There's really become increased attention to advanced directives coming into play, largely because of the growing ability to extend life with advances in medical technology. With some of the extraordinary measures that are available today, accessible in healthcare, people that did not survive 10, 15 years ago now are surviving for extended periods of time, but really also I think raises the question about the importance of advanced directives and having some of those conversations. So to break it down just a little bit, a living will really is speaking specifically about the written guidance for your agent regarding preferences for life-sustaining treatment. A living will becomes effective only when the individual is unable to make those decisions for themselves. And the real purpose of a living will really is to make your intentions known in writing. But the real power of a living will comes into the discussion that ideally takes place between the individual and their designated decision maker or proxy regarding those intentions when that durable power of attorney and living will gets written. Really to not have that discussion really diminishes the value of the living will and the designation of the durable power of attorney. So durable power of attorney for healthcare specifies the person or your agent who's to make decisions on your behalf should you lose that capacity. And in reality, a durable power of attorney has no authority until the time the patient or individual loses their capacity to make those decisions for themselves relative to healthcare. And we do find that, I find that sometimes people misunderstand that. Sometimes children maybe that have been designated as durable powers of attorney feel that they have the right or the access to a patient record of, say, their parent, when the parent is still very much full capacity. So that does require some clarification that no, that role of durable power of attorney does not come into play until the individual cannot make those decisions for themselves. One way of thinking about palliative care is as an umbrella over hospice care. Palliative care began in the hospice movement in the late 1980s, but it's much broader than hospice care. Palliative care really is focused on aggressive symptom management for individuals that may or may not have a terminal prognosis. And while hospice and palliative care are not considered faith-based care, the roots of contemporary hospice and hospice care has been religious and spiritual. Some of the earliest hospices in the modern era, such as St. Vincent's in Dublin in the early 1980s and Calvary in New York in the late 1980s, were founded by religious sisters, specifically to provide comfort care for the dying indigent. And of course, it is well known that the deep Anglican faith of Dame Cicely Saunders was instrumental in her founding of St. Christopher's Hospice in London and in her shaping of the contemporary hospice movement. So one of the key criteria for hospices is that the patient's primary provider must certify that that patient has a prognosis of 6 months or less, and that's a predicted prognosis. Patients may live beyond the 6 months of starting hospice care. However, the physician must continue to certify that based on their best clinical judgment, that patient continues to have a prognosis of less than 6 months. That 6-month prognosis is not a part of palliative care. That's not a requirement with palliative care. So let's talk just a little bit. I'm going to share with you what I found in the literature, and then we'll move on. There really exists a wealth of literature when we're looking at faith, spirituality, religion, and aspects of end-of-life care. And it's well documented that many people with serious illness or life-limiting illness engage in that process of reflection on the meaning of life and on major spiritual and existential questions of life. They frequently begin seeking hope, meaning, and comfort in their connection with the transcendent. and the literature clearly identifies that the majority of patients with advanced illness view religion and or spirituality as personally important and experience spiritual needs. As I noted earlier, the literature uses the terms religion and spirituality interchangeably, which makes it difficult to walk away with any real consistent themes or understandings relative to spirituality and end-of-life decision-making. At the same time, a number of studies drew a clear distinction between religiousness and spirituality, finding very different outcomes depending on whether individuals were identified as religious or spiritual. There were also a number of studies of people with serious chronic illnesses who were often able and willing to discuss most aspects of their spiritual beliefs and issues facing them. However, the concept of spirituality was too closely aligned with religion for them to be comfortable using the term spirituality. They were more comfortable speaking of big questions such as who am I, and where are we going? Reasons for life, suffering, and illness. And these were not always seen as spiritual questions to these individuals. There were a number of studies, however, identifying significant associations of spiritual support from the medical team, and in that literature they were defining medical team as physicians, nurses, chaplains, with receipt of hospice services, and among high religious coping patients with receipt of aggressive care. The authors of that study identified these findings consistent with data that support the role of spiritual matters in end-of-life decision-making. So the distinction was being made with that study was the significance of the role of the medical team in assisting with addressing the patient's spiritual needs, not meeting those needs, but addressing them. The study noted that high religious coping patients whose spiritual needs were largely or completely supported by the medical team were more likely to receive hospice and less likely to receive aggressive care, which they defined as care in the ICU, ventilation, or CPR resuscitation, compared to those not receiving spiritual support. Religiousness and religious coping have been shown to be associated with greater preference for and receipt of aggressive end-of-life care, and associations that may in part reflect unresolved spiritual issues in religious patients. Spiritual support may facilitate patients facing spiritual issues in being able to find spiritual peace at end of life, thereby creating more receptivity to a transition away from aggressive care. And a suggestion that perhaps greater discussion regarding the role of religion, spiritual beliefs in medical decision-making may help patients more fully recognize end-of-life care options that are consistent with their personal religious or spiritual beliefs. A number of studies identified that spiritual peace has been identified as a fundamental component of quality of life near death. And one study found that of 9 end-of-life attributes ranked in importance by patients, being at peace with God together with pain control was ranked highest. That study highlighted the importance of spiritual care in helping patients to both express and explore their spiritual dimensions of approaching end of life, ultimately assisting them in attaining spiritual peace. And finally, as I read through the literature on this topic, I couldn't help but ask myself, how are we preparing our healthcare professionals and our nurses here at Concordia College to facilitate patients exploring these important questions as they approach the end of life? One of the advantages to teaching and attending a private faith-based college such as Concordia is the ability to interject the concept of spirituality and religion throughout our curriculum. We do weave the concept of spirituality throughout our nursing curriculum from the sophomore year through the senior year, but I don't know how effective we are in empowering our nursing students to facilitate those conversations with their patients and their families. One study did identify that nurses are not often comfortable discussing spirituality, and as a whole, I believe that might be fairly accurate. But what this author did go on to state is that what is key is the nurse's openness to engaging in the conversation. And I think this could be said of all healthcare providers. Care that involves genuine presence, including awareness and responsiveness, and generous listening, may facilitate discussion and action and assisting patients and families with making faith-based end-of-life decisions. With that overview, I'd now like to take a few moments to share with you a very personal faith-based end-of-life story, that being my mother's death this past December 8th. I need to back up. I'm sorry. I actually got to cover this here piece first. We do want to talk a little bit about advance directives first before we get into that. Ever since 1991, when the Patient Self-Determination Act was signed into effect, healthcare programs have been federally mandated to inquire about and offer patients information about advance directives upon admission to that healthcare facility. And despite that legislation being in effect for over 20 years now, estimates indicate that the number of completed advance directives in the U.S. ranges from between 5 to 15%, a very small percentage. Which makes me inquire, I'm just curious in this room, how many people actually have an advance directive that's completed and on their medical record? So I think we're ahead of the national average, it looks like, but there's still some room for getting that into place. Ironically, despite lower than expected rates of completion of advance directives, having an advance directive has been associated with less likelihood of dying in a hospital and greater chance that a person's wishes will be understood and honored. So the role in faith in developing advance directives, an individual's faith plays a key role in creating those advance directives. Ideally, this should be a process of discussion, as I mentioned earlier, and review between patients, families, and clinicians that is sensitive to patient and family beliefs, emotions, values, and faith. It should be focusing more on goals of care and less on specific treatments. Ideally, it should be written and initiated well in advance of a late-stage illness and diminishing cognitive capacity. Hopefully when objectivity, faith, and values can drive the discussion. There are no right or wrong answers in writing advance directives, but it should be based on the individual's beliefs, values, and faith. Nutrition and hydration have such significant symbolism for us relative to how we demonstrate caring and nurturing in our society. Deciding as a family to forego nutrition or hydration, or deciding to discontinue hydration and nutrition can be a very painstaking decision, and one that's been known to lead to significant disagreements within families due to differing opinions. Reviewing some literature printed by the Catholic Church led me to believe that perhaps the Catholic Church is not as firm on its position regarding withholding hydration and nutrition as many think. Ultimately, the key really is on benefit versus burden. Regarding hydration, there's really little evidence that increasing fluids, such as IV fluids, helps to decrease dry mouth or the sensation of thirst at the end of life. And similarly, the use of enteral feeding tubes, such as nasogastric tubes or gastric peg tubes, does not reduce the risk of aspiration pneumonia or mortality. Quite the contrary is actually documented in the literature. At end of life, continuing to administer IV fluids increases the risk of heavy lung secretions. And in fact, excessive secretions, or what we call the death rattle, is the most frequently seen symptom in the last 48 hours of life. Approximately 56% of deaths in the one study I looked at had that symptom taking place. And that's a very distressing symptom to watch, especially for family. Likewise, continuing to administer NG feedings significantly increases the risk of aspiration in end of life. Aggressive use of nutrition and hydration at end of life actually increases the likelihood of distressing symptoms at end of life. Decreased gastric stimulation or feeding actually results in decreased nausea, vomiting, and lack of hunger over time in end of life. And as caregivers in end of life situations, we encourage focusing on finding other approaches to demonstrate caring for their loved one for family. Oftentimes they're looking for something to do that demonstrates that caring, that empathy, and that nurturing. But we look for things such as providing a moist sponge to keep their mouth moist, providing a cool, moist cloth over their head, applying lotion to their hands. There's lots of different inventions that we can help family to take a part in to play that active role. In terms of resuscitation decisions, such as making no CPR decisions, whether to intubate or not, establishing code status, the statistics show that the outcomes after resuscitation within a hospital setting actually are very poor. In one study of patients with cancer who underwent resuscitation within that cancer center, 37% of those patients had restoration of circulation, meaning they had a heart rhythm that returned. Only 26% survived greater than 24 hours, and only 2% were discharged from the hospital. Those are very meager outcomes for resuscitation. And unfortunately, individuals with a complicated medical history and a number of comorbidities often do not understand the ramifications and likely outcomes of resuscitation. Oftentimes what we know is what we see on TV. They may survive the initial resuscitation only to be sustained in an ICU for an extended period of time before suffering a very complex death. The question comes down to that of, again, benefit versus burden. And lastly, selecting your decision maker for healthcare. The role of faith, again, in advance directives is multidimensional, but perhaps one of the most important aspects is that you identify a durable power of attorney that you have faith will follow and implement your advance directives. Your proxy should be someone that you trust wholeheartedly and someone that knows you very well. This is not the time to select the oldest child because it is the politically correct thing to do in your family. You want to select the person you know understands you and your values and is able to ask the difficult questions of the medical team should that situation arise. What's important is that you trust your DPOA to abide by your documented wishes. Again, your DPOA doesn't have the authority while you're still able to make your own healthcare decisions. They take effect only when you become incapacitated or are unable to make those decisions for yourself. Now I want to tell you a personal story. My mother, Betty, was a faithful woman of 86 years of age, and she was very active, a social woman, but she suffered from a number of medical issues. Kidney failure, she'd been on dialysis for approximately 8 years, a history of an MI, followed by congestive heart failure, significant peripheral vascular disease. And despite her health issues, she remained a very positive woman, an optimistic woman, lived independently down in Siston, South Dakota. She'd been a widow. My father passed away in 2008, so had been a widow for about 5 years. And I was her durable power of attorney, mostly because of my healthcare background. And I had taken the opportunity to have conversation with my mother about her advance directives and treatment choices. We had discussed CPR status, discontinuing dialysis. Actually, she's the one that asked that question, asked me what would happen if she just quit going to dialysis. Last Christmas, she stayed with us a week at our home here in Fargo. And during that time, she actually experienced 2 episodes during the night where, due to some vascular issues, and she had a dialysis access up by her neck, blood flow back to her heart was restricted, and her face and neck swelled up significantly to the point where she was gasping for air. And during the night, I heard her calling for me, and I came out of my room only to find her with a swollen neck and face and gasping for air. She was terrified, obviously. And that happened 2 nights in a row, sequential nights. Both times I drove her quickly into the emergency room, and it improved over time. But I think that episode really increased her fear of being alone, and the fear of that episode happening back home, and the fear of her dying at home with nobody around. This November, my mother spent a month with my sister in Minneapolis. Again, she was very up for whatever activities. If we told her we wanted her to come up and stay a week, she did, because she liked getting out. But my mother was not one for praying in front of an audience or leading prayer. She was a very private woman from that perspective, but a very faithful woman. So on December 6th, right as my mother was preparing to come with my sister back from Minneapolis to Fargo, and then I was going to take her back to Siston, she ended up suffering her second heart attack. And at the time, it wasn't very clear that that was going on. As you hear, women in heart disease is very different than men in heart disease and experience very different symptoms, so she did not realize she was having a heart attack. And by the time they got to Fargo, she was becoming increasingly short of breath, so they went straight to the emergency room and admitted her and found out that she had had another heart attack. But it was clear at that point to her and to me that this was going to significantly impact her future quality of life in a negative aspect, and it did. I, at the time, actually had just driven to Minneapolis with my son, so I was there and she was here, and I was hearing about what was happening, and I was not sure that I was going to see her alive again. But I knew I'd had conversations with her about what she wanted in her end-of-life care. And I was fortunate they were able to stabilize her. However, she was very dependent on a high amount of oxygen with a BiPAP mask, which is a tight-fitting mask on her face. And she really could not do much activity of any sort, even getting out of bed without experiencing chest pain. So I knew that that was not how she wanted to live, because she had talked to me about that, and she'd been very clear about that. When I got back, fortunately, 3 of my siblings, 3 of the 5 of us were in the hospital, along with a number of grandchildren, and we were able to be in the room. And amazingly, as long as she had that tight-fitting oxygen mask on, she was able to be very coherent, fully alert, and very much at peace with where things were going. And as soon as I came in the room, she acknowledged that she was ready to go. So we spent some time, visiting, sharing, and then decided we needed to have a care conference. So my siblings and my mother and I met with the cardiologist in the room, and I had already talked to the cardiologist, so both she and I pretty much knew where we thought we needed to go with this point of her care. And we presented that option, and right away my mother said, "Yep, that's where I want to go." What we were looking at was allowing time for everyone to say goodbye, and then getting her comfortable, some sedation, and then discontinuing the oxygen treatment. And she was very much at peace with that. She was very clear that she was ready to go and join my dad. There's no indecisiveness. There's no emotion. She was happy. She was excited. It really was a very positive experience. She was so fortunate in that she had the opportunity. I think she recognized that she no longer had to worry about dialysis. She no longer had to worry about dying at home, what that experience was going to be like. She knew what it was going to be like. It was going to have her children around the bedside with her. So she was lucky and had the opportunity to call each of her grandchildren and say goodbye. And they were obviously emotional. She was not. She was happy. I didn't see her shed a tear that whole experience. She was so ready. And she actually, the dialysis nurses down in Siston heard what was taking place. They started calling in and wanted to know if they could have an opportunity to say goodbye. So we had phone calls coming in like crazy, calling her to say goodbye. And once we got to that point where we felt like everybody had had their time and she was ready, we decided as a family to just have a kind of a spontaneous group prayer. So those of us in the room just gathered around, held hands. And as I mentioned again, my mother was not one to pray openly or especially pray in front of a group. I don't know, to be honest with you, that I'd ever heard my mother lead a prayer in all my time. So I started the group prayer, and we just, went around, and anybody that wanted to chipped in. And I was sitting right next to my mother, holding her hand. And lo and behold, in the middle of it, she jumps in and prays very loudly. And thanking God for all the blessings that she'd had in her lifetime. I think she had the longest prayer of any of us, which was amazing. And nobody really said anything about it until after the fact. And my brother talked to my oldest brother, mentioned how that totally blew him away. And at that time, it did me as well. But it also confirmed how ready she was. So it really helped to verify that she was ready to go. At the completion of the spontaneous prayer, we also did the Lord's Prayer together. Then we had the nurse come in and start to administer the sedative and pain medication, and got to the point where she was getting very sleepy. So my son, who ironically is a funeral director, pulled up his little iPad and said, said the 23rd Psalm as my mother went to sleep. And it was beautiful. We could have not had planned that if we had tried to. It was such a peaceful death and such a beautiful death. And all of us kids continued to talk about it, what a beautiful process that was. But again, I think it really speaks to the importance of faith in decision-making and that end-of-life decision-making. And she really just role modeled for us what that can be and should be. So with that, I'm going to turn us over to Lauryl and let her share some of her experiences that she's had as a hospice chaplain. She's had many similar experiences, beautiful experiences, so it's all yours.
Great. Oh, and those real stories, they're the most important, aren't they? It's just, thank you so much for sharing about your mom. That's wonderful. I am a hospice chaplain. I work with the Hospice of the Red River Valley, and it's a privilege. I am privileged every day to be able to accompany people in one of the most important and most sacred times of their lives at their end of life. And I have a front row seat to observe and respect how people's... Oh, sorry. Jack is our technician. To observe and respect how people's faith informs their end-of-life decisions. And whatever people's faith or spiritual path, and I'm thankful to Jack for providing some definitions around that, because really it's so diverse. Now, our faith does shape, and it focuses, it prioritizes, it guides our end-of-life decisions. As a hospice chaplain, I am not there with people to evangelize or proselytize with people. I listen, and I offer spiritual support as people find their peace in their end-of-life journey. I see through these people how faith can help us find our way through the changes and the losses and the grief and the fear and the anger and the guilt. Faith helps us recognize what our real hopes are, what our strengths are, and who is there with us. End of life has a way of narrowing our vision to what's really important. And faith at the end of life, I've seen it bring amazing things. I've seen healing, not curing, but deep healing in relationships, reconciliation, a healing in finding meaning and purpose and peace for our lives. Not all of us are blessed to be able to make end-of-life decisions. Sometimes those are made for us. There are some key decisions, though, that many people will make at the end of life, and I observe how faith informs each of those. One of those key decisions, and Jack referred to that too, it's like, when to decide, should I continue or not continue aggressive treatment? We have so many options today. That's one of the blessings that we have, but unfortunately, sometimes when you get on the treatment train, it's really hard to know when to get off. It helps a lot to have thought through some of the issues that Jack described in the advanced directives and have talked with someone that we love. And it could be that person who's going to be it should be the person who's going to make the decision for us. But I also think it's so important to have that decision or have that conversation about our advanced directives, the things that are our quality of life, to have that discussion with all of the people who are going to want to make or have a voice in those end-of-life decisions. Because I see that happen sometimes, that one family member knows that, but then the brother or sister comes from out of state and they have a different opinion. So it's important to wrap everyone into that conversation. In discerning when to stop treatment, it really helps to have thought through what quality of life means for you. What's most important? Do I interpret my faith as saying that I need to keep on going and never give up? Or when can I faithfully know that I have done what I can do in this world and feel that it's okay to ask for comfort measures and to trust God or the sacred with the rest of my life? And who helps me? What helps me discern that? For some people, it's prayer. For some people, it's scripture. For some people, it's visits with pastors, with their doctors, with their spiritual guides and spiritual leaders of their traditions, with their family, conversations. Years ago, when I learned about ethics principles in these kinds of decisions, I learned that the principle of autonomy is the number one principle guiding our decisions. But recently I read another book. It was put out by the Hospice Foundation. It's called End of Life Ethics, a case study approach. And they make a very convincing argument that autonomy suggests that we live kind of as islands unto ourselves, and that is not the way it works. We're part of systems. We're part of family systems. We're part of faith systems. We're part of community systems and cultures. It's not our individual autonomy that helps us discern some of these really big questions. It's our relationships, the relationships that we have within our faith and our families and our communities that help us discern the best choices. Another decision at end of life, what would be a good death to me? What would be a good death to me? Have I observed some? What is it about that good death? Like Jack, you were describing for your mom. What a model of a good death. How does my faith, how does my spirituality, how does my religion, my culture inform that decision? There are some religious and cultural traditions that define and help people make some of those decisions about what and where and what to wear and things like that for the end of life. Where would I like to live out my final days? You talked about your mom and not wanting to be at home alone, but wanting to be surrounded by family. And most people want to be with their family. Most people want to be at home. So how can I do that? Is that going to work for me and for my family? If that's not going to work for me at home, if my spouse is too frail to be able to take care of me at home, or if my children are not going to be able to take the time off or move from another state to be able to help me to stay here at home, is it going to be okay for me to move into a nursing home? Is it going to be okay for me to be in an assisted living facility? Is it okay for me to die in a hospital intensive care unit? And if that's where I'm going to be, what will I need to make that the death that I would like it to be? And who would I want to be there to help me? Faith communities can be a wonderful wonder. I see our parish nurses out there, and faith communities are just so important to us to help with the physical, with the spiritual support at end of life. I have a client who right now, she used to go to Bible study all the time in her with her faith community, and she's just not able to do that. So her faith community said, okay, we're just going to come to your house, and we'll have Bible study at your house. So that's a wonderful spiritual support for her at end of life. What do you want as you are dying? Are there some rituals that are very important that you would like to receive from your priest, from your pastor, from your rabbi, from your imam, your spiritual elder? Is there music? Are there some readings that you would want? Are there things that other people can provide that will help in your transition? And after you die, another decision, what do you want? Have you communicated what you want to be done with your body? Do you want to donate your organs? Do you want to donate your body? If you're living in a nursing home or assisted living facility, a lot of them have what they call a ritual of transition today. So bodies aren't just taken out the back door. Bodies are allowed to go through a ceremony, a ritual of transition where they are brought through the hall so that the staff and the residents there can offer their respects and their love for that person. Do you want your body to be cremated? Do you want your body to be buried? Where and by whom? These can be really important issues within families. And if you've had a chance to talk about those ahead of time with that decision making, I see that as being very helpful. Do you want a service, a memorial, a funeral, a visitation, an open casket, urn, music, readings? Decisions that people oftentimes would like to make. And sometimes when they can make those, it gives them more of a feeling of control in their end of life, and it can also give them a feeling of peace when they've been able to make these. Another one, how will I deal with the pain and the suffering of dying? Would I want medications? Would I want a religious or spiritual leader with me? Would I think about suicide? There's a difference between pain that people are suffering physically and spiritual pain that people are suffering. And the spiritual pain of things like grief or guilt or despair or the fear of judgment by God, these can add greatly to the physical pain that a person feels as they are dying. And there are some studies in this area, I thought it was interesting, that find that spiritual pain for women is more likely to be in the area of a broken relationship. Spiritual pain for men is more likely to be in the area of guilt that people are carrying. And so if there are ways that at end of life you can identify people or something that will help you with some of this spiritual pain, it will certainly help with the peace at the end of life. How does my faith guide me in these? Do I connect with it in prayer? Do I connect with it in music and devotional readings? Faith traditions are such rich resources, especially when we're dealing in some of these areas of spiritual pain, when we're dealing with guilt and needs for forgiveness, for confession. And also, faith traditions are resources for dealing with the why questions, with the unknowns, with the mysteries, with those things that none of us can really answer. And another rich resource for us are the experiences that we or others have had in the past as God has helped us with our crises. I sometimes read, for people who come from a Christian tradition, I will read lament psalms, or I will read scriptures of deliverance or stories of God's help through suffering to remind people that others have gone through this already and that we too will be carried through this time. A young man that I visited last year was dying with cancer. He told me that he had been raised in the Christian faith, but that he just found it wasn't what he was looking for. And so he had spent his adult life seeking through many different religious traditions, and in some of them he had found great meaning and peace. At the end of our conversation, and oftentimes when I'm visiting with people, when I leave, whether I'm part of their tradition or a different tradition, I'll often offer, if they would like to pray, the prayer that he wanted me to pray with him at end of life was the Serenity Prayer. And so we prayed that prayer, and in that he finds great peace. How does faith help me cope with fear at the end of life? Do I deny it or escape it or fight it? Do I submit to it? Do I face it? Do I consult with those I trust? Do I pray about it, research it, Google it, live with it, medicate it? Probably all of the above. I hear things every day like, I'm afraid that I won't be able to breathe. I'm afraid that the tumor's growth will cause terrible pain, and I don't want my children to see me like that. I'm afraid that I will be a burden for my family, physically or financially or emotionally. Or I'm afraid that I won't be saved. I won't go to heaven because I haven't done what I should have been doing. Many years ago, back in the early 1980s, one of my community theater friends was diagnosed with AIDS. And back then, the disease was brutal and aggressive. And he had been raised in a traditional Roman Catholic faith. But with his lifestyle, he felt excluded from the church and condemned by God. And although I knew that his faith was important to him, I did not have the words to reach him about Jesus' grace. But God works in mysterious ways, and I'm so thankful for that. A priest was dying in the same hospice home as my friend. And Bob called me one day to say that he had been spending his days talking with a priest, and in that hospice house had received the sacraments of his faith and found his peace. Our faith traditions give us rituals, they give us scripture, they give us prayer to care for our fears and to help us face them. I was visiting, in fact, just this morning with one of my clients, and last summer when she found out that she was going to be starting on hospice, it was a particularly difficult time for her family because her grandson, just a little while before that, had been killed in a tragic car accident. And so the family had not only his death to grieve, but their mother's starting on hospice to grieve as well. And the family, because she wanted to stay in her home, the family, all of her children, decided that they would take time off work and they would come and spend a week at a time in her home with her. And it happened to be the week that her daughter, who was the mother of the young man who had been killed in the car accident, it was her week to come and spend with her mother. And one night in the middle of the night, she was dreaming. And she had a very, very vivid dream. And she dreamt that her son was standing at the foot of her bed, and he looked alive and well. And she said, "What are you doing here? You're supposed to be in heaven." And he said, "I've been there, Mom, and I came back. And I'm going to stay, and I'm going to wait until Grandma's ready. And when she's ready, then I'll go with her." And the next day, the daughter told this to her mother. And when I talked to the two of them about this, they both cried. But I asked my client, "How did that make you feel?" And she said, "Lauryl, I'm not afraid to die anymore. I feel so much comfort, and I feel so much peace." And I believe that it's our faith traditions that can help us interpret and find our hope in these experiences that we call near-death awareness. And I've heard so many of these that I believe God sends to give us that peace and that hope. Another decision is, what would I like my legacy to be? What will help my family after I leave them? Not just the will or the trust or the endowment, but the things of the Spirit that never rust or wear out, the things of love that never ends. Dr. Dovery is one of our hospice volunteers, and I've heard that you sometimes help people to write their legacy, write down their stories of their lives to leave with their families, and this is such a great gift. I thank you so much for that. And in a shared faith, we can entrust our families with the ongoing care of a faith community and of others like hospice who walk with them through their grief and help them stay connected to hope and to life and to faith, trusting in a new and a good life for us and for them when we die? How can we leave our families that legacy, that blessing? And I have another story. There was a woman, one of the clients that I was working with, who was so looking forward to attending the wedding of one of her sons. And it was several months away, but she'd already picked out her dress, of course. She was ready for that wedding and so excited about it, and as was all of the family, of course. But as the wedding day drew near and near, it was apparent that my client was getting weaker and weaker. And when she became bedbound and too weak to write and difficult to speak, I approached her one day and asked if she would like to write a blessing for her son to be read at the wedding. And I said, if you're feeling up to it, if you're strong enough, it's one that you can read to give as a blessing. And if not, maybe someone else could read that for you. And she said, I'd love to do that. And so, being too weak to write, she dictated to me what she would like to leave in a blessing. And I wrote the blessing, a beautiful, beautiful mother's blessing for her son and for his wife-to-be, and wrote it, and then I stuck it in her Bible. And a few days later, she passed away. And the person who was with her at her bedside was the son who was going to be getting married. And to comfort himself, he picked up her Bible. And he started looking through all the places that she'd underlined and circled, and it gave him great strength. And then he ran across that blessing that she had written for him and for his wife-to-be. And I called the next morning when I heard that she had passed away, and he's the one who picked up the phone, and I offered my comfort and prayers for him. And he said, Lauryl, I was looking through my mom's Bible last night, and I found that blessing that she had written for me. And I said, oh, I'm so sorry. I said, we were hoping that could be read for you at your wedding. And he said, no, I'm so glad that I found it last night. He said, I cried and cried when I read it, and now it can be read at my wedding, and I'll be able to get through my wedding. It will be wonderful to have with me always. Another question, how would I like to handle the things that are still unfinished in my life? What's really important to complete? As I said, our end-of-life focuses us, narrows us on, we look at some of the material decisions in a different way. We look at relationship issues as a much more important part, and the spiritual and religious concerns. Are there some conversations that I need to have so that I can be at peace? Peace with my family, peace with my friends, peace with my faith, with what is sacred in my life. Dr. Ira Byock is a man who has spent a lot of time working with patients at the end of life, and he talks about some of the most important gifts that we can share with each other at the end of life. And these gifts are saying, I love you, and thank you, and I'm sorry, and I forgive you, and even the gift of saying goodbye. And I sometimes think for those of us who are having a hard time struggling with how to say goodbye, if we can even frame that goodbye within those gifts. I love you. Thank you. I'm sorry. I forgive you. Goodbye. I will see you again. That can be very helpful. What are the words that you want to hear? And who do you want to hear them from? And finally, I want to share another story that, we in hospice work a lot with the clients that we are asked to serve, but in addition to that, we also work an awful lot with the families. And I met a wonderful man here a few months ago, and when I first went in to do an initial assessment with him, he was very, very confused, and it was a little bit hard to follow the conversation because of his dementia. But we actually had a wonderful conversation, and so I left his room and I called his son, and his son lived from out of state, and I introduced myself as a chaplain and said that I had just met his father and asked if there were any things that he would particularly want me to do to support his father's spiritual life. And he said, oh my gosh, Lauryl, he said, I can't even believe that my father would let you in the room. He said, he is, he used to be this pillar within our church community. He loved his faith. He was a leader in the community, in the church. And he said, when my mom died, he had a spiritual crisis. And that was it with God as far as my dad was concerned. He said he would no longer want us to talk about God in the home. He did not want to go to church anymore. He wanted nothing to do with his faith at that point. And he said, so I can't imagine that he is going to allow you to talk with him if he knows who you are. And I said, well, I actually just had a really good conversation with him. And I'm not going to be pushing religion. I'm more going to be there just to accompany him in his end of life and be someone, as I believe, who's there to really love him and respect him. And so I had a few more visits with him, and some of them were, we had more conversations. Some of them, not so much, depending on what kind of a day it was for him. But one day I went to visit him, and he was sitting all by himself or at a table all by himself. There were a few other people in the room, but he was at a table all by himself in the room. And so I came and I walked up, and I just sat down next to him. And he looked at me with the strangest look, and he said, I think you're the angel who just bit my ear. I said, oh. And he said, and no one else in this room can see you. I said, well, what should we talk about? And he started talking with me, and he talked for probably 10, 15 minutes. I just listened. And he talked about heaven and hell. And I could see, even with the confusion, I could follow the difficulty and the struggle that he had been having in his faith. And he was working through those as he talked with me about those. And at the very end, he said, I hope that when I get to heaven, I'll see my grandma, because I know she loves me. And I said, I think when you get to heaven, you're going to see your grandma. And he just sat back, and he just breathed this sigh of relief and this peaceful look over his face. And I came out of that just feeling like, wow, what happened here? And I called his son, and I told his son about this, conversation that we'd had. And his son said, oh, my, Lauryl. He said, I can't tell you how much that means. That you were there to hear that, and that my dad could have said those things to you. He said, not only does that mean so much to me, but he said that's going to mean so much to all of the family of my dad. And he died a few days after that. It's such a privilege to be able to walk with people, to accompany them in all the decisions, and to see how important our faith is at the end of life. Thank you very much. Thank you.
Since we have run out of time.
Oops.
Can you hear me? Okay. Apparently this isn't on. So we don't have time to ask corporate questions, but Jack and Laura will be here for a little while longer, so you can have a conference with them. And thank you so much for showing up today. Next month, March 14th, we shall be talking about maintaining the public trust with Delton Steele and Charles McFarlane. Please come again. Thank you so much for coming.